everybody. Welcome back to Psychedelics Today. This is your host, Kyle Fuller. Really excited to have Dr. Devon Christie and Will Siu on the show today. Really excited to chat with you both about psychedelics and pain, and we'll dig a little bit into somatics as well. Dr. Devon Christie, would you like to introduce yourself and let the listeners know a little bit about your work and who you are?
Sure. Yeah. Thanks so much. It's a pleasure to be here and excited for our conversation. So a bit about me. I'm a family physician with a focused practice in chronic pain management. I'm here in Vancouver, BC. And I'm also a registered therapeutic counselor, and my focus is in relational somatic therapy, so an emphasis in trauma resolution. Did that training while I was preparing myself to become a MAPS-trained therapist. I learned about the amazing work of MAPS and MDMA-assisted therapy for PTSD and just thought, wow, I want to be involved in that. And so along the way, I've just been going deeper and deeper down the rabbit hole of different ways we can understand, why we're sick and how we heal. I'm also a longtime meditator, yogi. I teach the mindfulness-based stress reduction program, certified through UC San Diego, and interpersonal mindfulness as well, something I did through UMass. And I'm a teacher too, so I'm super passionate about part of what we're talking about today, which is trauma-informed somatic approaches and how these can synergize with psychedelic-assisted psychotherapy. So that's the emphasis of what I'm teaching in the California Institute of Integral Studies certificate program in psychedelic therapy and research, as well as a couple of other institutions, the Integrative Psychiatry Institute and their year-long psychedelic therapy program, as well as the Anka Institute. I'm also doing some research. So I'm the principal investigator here in Vancouver on an open label compassionate access trial investigating MDMA-assisted psychotherapy for PTSD. And that's going to help give Health Canada more safety data that's going to support the eventual regulation of MDMA-assisted psychotherapy here in Canada. And as we'll talk about too, I'm really interested in the interface between psychedelic therapy and pain. And that's what Will and I are kind of working together on. And I'm the Medical and Therapeutic Services Director for Numinous Wellness Inc, which is a company that's, we're a mental health company, and we're really working hard to translate all of the exciting science of psychedelics into clinical practice, using best practices, evidence-based approaches, and being a bridge to bring that into our healthcare system here in Canada.
Wonderful. Thank you so much. Sounds like you have your hands full and so many great things that you're doing.
Lots of stuff. It's good.
Yeah, hard to balance, I can imagine. Will, you've been on the show in the past, but you want to give listeners a little bit of bio about you?
So yeah, my name is Will Siu. I am a psychiatrist in Los Angeles, California. I also, in addition to getting my medical training and becoming a psychiatrist, I have a science background. So I have my PhD in immunology. So I was very much a lab scientist for a lot of my life. For those maybe that haven't heard from me before. So I didn't have a sort of a traditional path into psychedelics. Sort of early on in my training, I didn't try my first psychedelic until 33, 34. I was terrified of these things. I was raised Jehovah's Witness. There was many, many things stacked against me in terms of thinking I would ever take a psychedelic. So in many ways, I think my work sort of mimics and is in parallel to my own personal healing work. I now have a private practice. I see most people weekly for 1 hour a week therapy. Most people have some connection to psychedelics. That see me. I have been doing ketamine in my practice for about 3 years. I'm MAPS trained for the MDMA-assisted therapy for PTSD. And I think relevant to, I'm advising a couple of companies. I'm sort of moving right now from this private practice, one-on-one work to almost, I was talking to somebody earlier today. It's almost thinking about how to be a therapist or a psychiatrist to companies and other people in the space that are opening up and helping them to sort of spread how to educate or how to work with psychedelics and how to, move the field forward. So I've been moving more into sort of education and training in the last year or so. And yeah, I mean, in terms of today's topic, I think it's something that's been fascinating to me because I thought, a lot of healing in the beginning of my training was, brain problem. A neurotransmitter problem. And then I went from that to, oh, it's a mind problem. So let's, do psychoanalysis, which I did for 4 years on the couch, Freudian style for 3.5 years. And then I started getting more into the body and spirit, through my personal, experiences with psychedelics and working with clients, and really, so all, just building in the mind body spirit connection, which I think psychedelics provide a beautiful avenue to do. And so my interest in pain really came because I was, in some ways, I think psychology can be very masterful at addressing emotional pain. But then it became very clear to me after that, people often were suffering from both emotional and physical pain, or sometimes just physical pain. And where, as a physician, I used to think that physical pain meant there's a structural problem. I started really realizing that physical pain can actually be also due to mind or emotion based problems. And then, psychedelics, I think, are, there haven't been large studies so far, but I mean, Devon will probably talk about a little bit about her analysis of some of the MAPS work. But yeah, I think we're going to have the opportunity very beautifully to connect this, the thing that we call mind body or psychosomatic, which, 5-10 years ago in medicine, no one was even, it was this woo-woo area. And so I think we're going to be able to really connect this in a scientific way, and psychedelics are going to be a big part of that. So that's my little intro.
Yeah. Awesome. Thank you. Yeah, there hasn't been too much research on psychedelics and pain. The only thing I can really think about is what during like the 60s, Eric Cast studying like LSD as an analgesic and having those like pain reducing qualities. But not too much up to date research in this field, right?
Yeah, it's kind of an emerging field. UCSD, I believe it's UCSD, just has launched a program looking at classical psychedelics and some pretty severe chronic pain conditions like cluster headaches and phantom limb pain and complex regional pain syndrome. And there's lots of exciting kind of mechanistic ways we can chat about that, where, theoretically these substances and how they're working in the brain, areas like neuroplasticity and such, we expect and are hopeful that this will confer benefit in people that experience, quite debilitating conditions. And now Will and I are interested in fibromyalgia and conditions of central sensitization. And, to just dovetail off what Will was sharing kind of about his personal experience too. I mean, that's always been my path as well, this parallel sort of exploration of, how to heal my own, what I've been struggling with through my life, and happy to speak super openly about that, later in my teens, having an eating disorder and depression and working through that. And then, initially through sort of the mainstream methodologies, medications, cognitive behavioral therapy, and that kind of thing. And then later, once, the behavioral aspects had long been, I've been recovered from, but the deeper layers of what was driving, an eating disorder as a coping strategy in the first place, so much more related to, just early developmental trauma and relational and emotional neglect and these other things, where I feel that, through the journey, my own journey, through not only understanding trauma and trauma resolution, but with psychedelics, it's like the ability of these substances to get us really to drill down into some of these root causes that are, however they're showing up, whether they're showing up as an eating disorder or whether they're showing up in chronic pain, which is also something I've struggled with, since I was a teenager. I've had low back pain on and off, and sometimes quite debilitating. And then later on, even got to experience PTSD after a series of head injuries and car accidents. And so really super passionate, like the same way Will is. And this is sort of how we've connected here in terms of understanding that this holistic approach that does incorporate all aspects of our being, mind, body, and spirit, is something to be explored, to be researched more, and I think can apply not only in psychiatry, but as we're speaking about, certainly in chronic pain, which itself is a very complex condition. It's a condition in its own right, but there's overlapping mechanisms centrally in the central nervous system around pain processing that involve emotion and emotional valency and sort of biases towards negative emotional experience and negative cognitive appraisals, as well as our fear systems in our brain. There's a real avoidance and perpetuation of chronic pain that comes from really the pain being interpreted as this danger signal, and then fear and avoidance. And this is also what perpetuates PTSD. And we can talk more, but there's so much overlap between post-traumatic stress symptoms and chronic pain. And this is kind of what, as a pain doctor, got me thinking, MDMA works so well for PTSD, and PTSD and chronic pain overlap so much in my patients. There's got to be something here, and just was stewing on that for a while, and ran into Rick Doblin on the playa at Burning Man, and just asked hey, has anyone talked to you about chronic pain and MDMA, as a pilot study or investigating that? And ultimately Rick connected Will and I, because we were the two people that have kind of found our way to him and with this thread.
Awesome. Thank you for sharing for some of your personal story. And that was, I guess, going to be my next question of, how did you two meet and come together? I knew Will, when did we meet Will? 2014, 2015. And, you're already kind of tossing this out here about having this research interest in MDMA and fibromyalgia. So I'm guessing that was the connection there between you two. But anything else about
it's interesting because I think it's lots to say, but I think in part I was thinking about actually how you and I, Kyle, met was what got me more into the body and somatics, because the other, if I were to, two things that really hit home, or I guess maybe hammered into me that this is truly a thing, meaning there's a deep mind-body connection, and was holotropic breath work, which is how you and I met, and just seeing, just the shifts that happen with people and the strong physical symptoms that come up and how quickly and powerfully they can be ejected. And the other was with my experiences with ayahuasca, where it was just, I think there's none of the psychedelics I think can be so powerfully connected to, the body and purging. And then you see these huge shifts in my, at least for me, and those ended up being my, I can't doubt this anymore. I've got to look into it. It's kind of like what Devon was saying. And in the back of my mind for me, fibromyalgia was more of a rational thing for me, because it was I always felt that even to now, right, psychedelics are really focused on psychiatry and mental health, right? And if we think of PTSD, anxiety, substance abuse, and I have a sense, and there's lots of anecdotal stuff out there of people saying they have either chronic pain or autoimmune stuff, or even, curing of cancer at some places, with ayahuasca. And I think, there's enough stories out there, and I think that it's at least worth looking into it. But I also think I've seen and experienced enough of this myself to know that a lot of it is real, and so fibromyalgia for me is this it's this diagnosis within medicine that's kind of, most doctors, if they see it on their patient list for the day, are pretty scared, because they're shit, it's this patient that's suffering and I don't really have anything to give them. And they go see doctors of all sorts of specialties, right? You see family doctors, internal doctors, psychiatrists, everyone tries to help people with fibromyalgia, but they just, it's something that just does not, get much better. We don't really have great tools for it. And it's overlaps very strongly with PTSD. And so, it's been something that's been brewing for me as a nice low level or nice entry level way to test a psychedelic, and in particular MDMA, to try to bridge this, psychosomatic work. And that's, as Devon said, Rick connected us as people who are both very interested in this.
Mm-hmm. Yeah, I also met through a shared friend who's also a colleague in the field, Ailey Jolie, who connected us. So lots of lovely people bringing us together. Yeah. The other, as you're touching on sort of fibromyalgia and not having a lot of super helpful treatments, people continuing to suffer despite, maybe being prescribed antidepressants or other things. Some of the more promising things that I've seen helping my patients with fibromyalgia tend to be things that are helping them to work on neuroplasticity, work on shifting their relationship to stress, to events and to stressors externally, internally. There's brain training programs that some of my patients are looking at, like dynamic neural retraining is one of them that actually McMaster University did some research in and actually showed some pretty promising results at 3-month follow-up with a cohort of people with central sensitivity syndrome. And so it's kind of pointing at there's processes in the brain that are, that through neuroplasticity we can learn and we can retrain that and the research on mindfulness very much supports, shifting our relationship to stress, calming the fear centers in the brain, shifting our relationship potentially to how we're experiencing pain in our bodies, our emotional experiences. So then when you take that foundation and consider what's possible with psychedelics, and particularly MDMA, in my opinion, really giving like a boost, like accelerated access to what's possible in shifting our perceptual states, in harnessing neuroplasticity, in reappraisal and even reorganization of traumatic memories, and sort of what we're learning about how MDMA works on the brain and reducing fear and activation of parts of the brain like the amygdala, which is like our smoke detector for threat, and the hippocampus. And, it's just, Will and I are just super excited at the prospect of seeing what happens when we do this. Like we know from other indications like PTSD that MDMA-assisted psychotherapy is just like supercharging therapy and really opening up access, like a window to confronting traumatic memories, to confronting very challenging emotional experience that otherwise, without the support of the medicine of the MDMA, are very difficult, if not impossible, to do in just standard psychotherapy. So yeah, I mean, those are just like some of the things we're thinking about in terms of how this might really serve to accelerate people's healing journey. Recognizing that, this sort of silver magic bullet or one cure, especially in chronic pain, is something, I spend a lot of time counseling my patients. It's not about that. We have to take a multidisciplinary approach. We know that the gold standard in pain management is through the biopsychosocial model, which recognizes there's biological events, there's inflammation, there's maybe genetic predispositions and other things. And there's also our psychological frame and our social context. And, what about the relationships in our lives? And how are we supported? What we see with chronic pain is people are very isolated and often self-isolate. And again, that's another thing that's like MDMA, we know, increases feelings of connection to oneself, to others, really supports sort of a pro-social attitude, which hopefully will help our chronic pain patients to also reconnect in positive ways that's going to be supportive for their healing journey.
Are you guys actively working on a research project right now, or putting a proposal in? Or I don't know if that's something that you can disclose if you're in the early stages.
Yeah,
sure.
Do you want to speak
can.
to our collaboration?
Sure.
Well, how about I speak to just the sort of the baseline research that's providing a bit of a rationale for this. So myself and some colleagues submitted a data access application to MAPS and got access to some of the accessory data collection that was done in the MP16 study, which was like a lead-in study to the phase 3 study. And so there were 35 participants, and the chronic pain grade scale, CPGS, was collected at baseline and then at study termination, which was an average of about like 5 months afterwards from the baseline measurement. And so this was an accessory data point, and really no one had done anything with it, but collecting a lot of different accessory data so that later on folks like us can go in and go, what's happening here? And comparing that to the primary outcomes, which was in this, the clinician administered PTSD scale. And so with some help from a statistical analysis, we found that through kind of heat mapping and finding clusters, there was 84% of our study population, which was only 35 participants, all had chronic pain in addition to PTSD. So it's very high. So it's kind of, it's estimated that, somewhere between 50 and 80% of people with PTSD have chronic pain. So it's sort of coming in at the higher end of that in this sample of people with severe PTSD. And the folks that had, we did 3 clusters, and the middle cluster, which was the moderate PTSD scores in the group. I mean, they all had severe PTSD, but the middle cluster were the folks that had the highest pain. And they were the folks that ended up having a statistically significant drop in their chronic pain grade scale at termination. So P less than 0.5 for those statisticians out there. So even though it's not a big sample, it's certainly really promising information, especially since the intervention wasn't even geared at chronic pain. So often when someone comes into a study and they know the intervention's going to address their issue, there's that, a boost around like placebo or expectation, right. But none of these people were expecting that the intervention necessarily would have any impact on their pain. And then in the other 2 clusters, there was a trend. It wasn't statistically significant, but certainly a trend. So this is all just really supportive of the question that Will and I are asking. So I'll hand it over to you.
Yeah, and so the reason, I sort of shared earlier about this fibromyalgia and circling of that I've been doing around that for a few years, because I'd been sort of dreaming about, so if there's sort of an initial study I wanted to do of a psychedelic, or namely MDMA, for something that's non-psychiatric, where would I start? And so I'd circled around a bit with fibromyalgia, but also, psoriasis, or there's a couple other things that I had been thinking for a bit. And so, but again, the connection between fibromyalgia, PTSD, the untreatability of it, et cetera, was something that had attracted me. And so, for me, it was also then these personal experiences, having a lot of my physical symptoms shift after psychedelics, and also working with clients that sort of, we're clustering up to make, what made sense most for fibromyalgia. And so that's sort of when Devon and I connected, and she was working on the project that she just described. And so, we spent some time thinking about potentially what pain disorders should we try, different ones, et cetera, but ultimately landed on, going for a fibromyalgia, MDMA for fibromyalgia pilot project. And so, we're in the process right now of working with MAPS and their IIT, which is their investigator-initiated trial program, to help clinicians like ourselves who are just very curious and want to test out other indications with MDMA. And so, we're in the process of doing that. And so, we would do a 2-center open label trial with a small number of patients, something like 10 to 15, over in Vancouver, where Devon is, here in Los Angeles. So, that's what we're working on.
Is there a reason why focusing on MDMA versus like psilocybin or any of the other medicines? Like, what particular about MDMA is interesting for chronic pain?
Do you want to go?
We haven't actually.
I can chime in. Why don't you?
In particular, so it'll be interesting. Go. I'd love to hear what you have to say.
Yeah. I mean, well, I recognize there's promise in the realm of classical psychedelics for chronic pain. Personally, MDMA-assisted psychotherapy is really where my heart lands in terms of the type of work that I want to do with folks. And, there's so many paths one can go down as a therapist, and it just really feels like this relationship to MDMA and the therapeutic potential and the healing potential that it specifically brings forward, in contrast to other classical psychedelics, is just aligned with kind of my therapeutic approach as a relational somatic therapist. When folks are under the influence of MDMA, it doesn't have that ego dissolving mechanism that the classical psychedelics do. In general, people are still quite conscious and aware of themselves, and in the PTSD studies, tend to pendulate back and forth between being more internal in a process where they're, encouraged to just allow whatever's coming to surface and just connect with this inner healer or innate healing intelligence and sort of trust that that's bringing whatever experiences forward that are needed with the support of the therapist there, and then pendulating more into this kind of relational frame where there's more talk and connection between the therapist and the participant than we typically see in more classical psychedelic work, where it's more really this internal journey, eye shades, headphones, and kind of support in general, right? Just speaking in generalized terms. And specifically the type of relational healing too that I think MDMA brings. A lot of what underpins and I think sustains a lot of people's wounding and trauma and pain is sort of the scars of early relational deprivation, emotional neglect. When we're children, we're so sensitive, and we're not born into the world learning how to name our emotional experience or learning how to even self-regulate our emotional experience. Infants and small children are absolutely dependent on their caregivers to learn regulation. So it starts off with co-regulation. Caregivers' regulated nervous system gives an input to dysregulated crying baby's nervous system that, I can settle. And then there's, ruptures and repairs and all kinds of things that happen through attuned reciprocal engagement between developing children and present caregivers and emotionally attuned regulated caregivers that literally build the architecture in the brain to later in life be able to self-regulate. So when that's missing, it becomes a vulnerability. And I think a vulnerability to developing stress-related conditions, probably many psychiatric conditions. We have this system of DSM classification that really silos things according to symptom clusters. But I think we're moving more towards like a transdiagnostic understanding of these fundamental things that underpin a lot of different conditions that just show up differently depending on, individual situational factors and other contextual factors, or maybe genetic vulnerabilities. But so to bring it back to MDMA, I just see, therapeutically, there's such an opportunity for relational healing and corrective emotional experiences with attuned therapists that are present, two therapists in the model, right, with one client for 8 hours, plus all of the preparation and trust building, and then how the trust and the alliance is enhanced with MDMA, and then in the integration following. So personally, I just think all of that aspect of the healing that MDMA brings is so fundamental to healing stress-related conditions where, it's not just about what happened to you, the trauma, but it's also about who was there or who wasn't there. And what were the relational ruptures, either through your development or at critical periods across your life. And MDMA really brings that possibility as a more engaged relational kind of therapeutic process.
You're just pointing on that point. I guess I'll share a personal experience I just had last weekend with a body worker. And I was coming out of another session, and that piece came up from an accident that I had of like tapping into the emotional relational part of that trauma happened to me, but I was lacking these certain relationships. And it was just so interesting to kind of dive into that by activating it through body work and then going into those emotions and noticing such a change in the way my body was like processing that, because there's usually like all this tension, and just noticing some relief and not even being aware. I've been working on this trauma for, I don't even know, like 16 years. And it's like the more I dig into it, I just keep learning new things about it. But yeah, that piece was huge. It was like a huge insight about like, oh my God, like I didn't even realize I was missing that. And it's really interesting.
Yeah, and psychedelics, including MDMA, can really open us up to experiencing our embodied selves differently, perhaps creating more resource for us to even experience ourselves in an embodied way. Many people with trauma are very disconnected because the body is just, it's holding the pain of trauma. People with chronic pain, often just working to kind of distract and sort of be out of their embodied experience. So there's this this doorway in through what's facilitated by the medicine. And that's where, my interest in somatic therapy too comes in, because psychedelics, they're not just changing how we think. They're creating so many different ways that our brains can connect the dots, including, all the different channels of our experience. And, people will have like spontaneous gestures that they do. And if a therapist is attuned on that level of body language, you can mirror that and activate mirror neurons. You can really ride and follow and inquire with curiosity into the person's subjective present moment experience, which encompasses felt experience and emotions, which we feel in our bodies. And when we give those experiences language in an attuned relationship, in the context of therapy, all of a sudden a person feels accompanied in a very different way. Like, oh, this person's with me in this kind of felt experience and exploration. And to me, it adds so much dimension. And as you said in your experience there, this possibility of really just like, oh yeah, like, and feeling ourselves in different ways. And in somatics, we have this trauma-informed lens informed by the physiology of trauma that, our nervous systems are capable of restoring equilibrium. But when that capability is blocked, trauma symptoms develop. And then we end up holding that trauma in our tissues, in our nervous system, in the fear parts of our brain. Tensing is part of fight or flight, right? So we start to hold that in our muscles and our fascia. And so when we start to process traumatic imprints, like implicit held traumatic imprints, with the language of somatic therapy, we can really encourage that organic process when we see it happening. So like examples, sensory motor psychotherapy, Hakomi therapy, somatic experiencing. There's lots of different submodalities under the umbrella of somatics, but I think it brings a lot and something to continue to emphasize, I think, in therapists interested in doing psychedelic work.
Definitely. I guess I'm a little biased too. And I want to come back to learn more about this relational somatic therapy. But Will, I also wanted to hear some of your thoughts about MDMA for chronic pain, and what was, your first like, I want to explore this. Why MDMA?
I was getting a little bit hypnotized by Devon's voice. She could be very it's very soothing. I was like, you should get into like reading bedtime stories or something. I feel like I could have just dozed off, but joking aside, so it's like for me, it's a couple of things actually. What I mean, and some of it is honestly practical, right? To me, right, there's all this excitement obviously around psychedelic therapy. The one that's furthest ahead right now, and by quite a bit, and is still probably about 2 to 3 years away, is MDMA, right? So I think some of it is simply practicality. I think as Devon touched on a lot of things, I would sort of summarize it also, though, as the gentleness of MDMA. I think, especially with the correlations with PTSD, I do think that not all psychedelics are created equal. And I think that usually we've tucked away these parts of us that have felt unexpressible or unlovable, right? That lead to the emotional pain or the physical pain. And I think that the gentleness is something that we really need. I think everyone can use more gentleness, but in particular, I think MDMA is known for that, right? And a third thing that it's also related is that I think about the openness of the science that MAPS is really pushing, right? MAPS and Rick is really interested in MDMA for many different indications, and they're very much dedicated to open science. And unfortunately, we have companies out there right now, especially around psilocybin, who are trying to use patent different molecules and different indications. Which to me, I understand that there's part of, there's a business and profit aspect that's necessary, but there's also an openness, I think, to and the commitment from MAPS to provide MDMA for different types of modalities. So that's another piece that also comes to mind for me. The other piece that I wanted to share that Devon was touching upon, and Devon, I actually was excited to talk to you about this at some point, but we haven't talked about this yet, which is the importance of having therapists who are really ready to have, different experiences come up in the room, and because as Devon was saying, you can have these very much reframing, deep healing experiences for people that can have these catharses and openness now to more emotion, more physical motion, etc. But I actually believe that you can also have these things come up during powerful psychedelic sessions. And if you don't have a corrective experience, it can actually lead to more conscious pain, emotional or physical, in the follow-up, because it's almost like this pain comes up.
Mm-hmm.
And and then unconsciously or consciously, if the person's like, oh my God, this thing now came up, I was alone with it. Like the therapist didn't know what to do with it. It can actually reinforce the initial trauma, except
Mm-hmm.
now it's been brought to the surface. So it's no longer unconscious and you can suffer more in the
Mm-hmm.
meantime. And so I was thinking about, Rick had been on some podcast recently where he was talking about how one of his worries is that the decrim and the political movement towards more open access to psychedelics is outpacing the science. And I think I was thinking about something similar where I think access to psychedelics, both medical or, just open access to the general public, is outpacing, I think, the trained people to know how to work with them. And I think that's actually a pretty big concern that I have, because I think in some ways, especially with the somatic work, there's definitely a bigger lag behind therapists who are working with psychedelics who know how to work with the body. And so, I don't know, it's just something that I was thinking about in the past week since you and I last talked, Devon, that it's great, I think, if we can have, again, these trained therapists, but we are way, way behind on this stuff. So I don't know, it's just a topic to bring up to both of you guys to see what you thought about that.
Oh my gosh. Yeah. I mean, hence my passion to be reaching, I'm so happy when Janice Phelps heard me speak at a conference and was like, can you please teach a module on this for our cohort?
Yeah.
I was like, absolutely, because we need therapists to be, learning about and integrate, because in many ways, the somatic approaches are kind of like cutting edge of just the sort of psychotherapy development, and not necessarily part of traditional, training when you're doing your psychology degree or even your master's in clinical counseling. It hasn't necessarily found its way into those curricula. It's usually something that's, postgraduate, going and doing some additional training and certification. So, but yeah, Will, I totally, we haven't had a chance to talk about this, as you said, but it's something that, in ayahuasca circles, especially, my concern about the level and the rates of emotional neglect and relational deprivation, particularly to people in Western culture, where you see other cultures where babies are just like held and carried around all the time, and there's just tons of touch and tons of contact, and even community around people, particularly in indigenous cultures or naturalistic based societies. Whereas here in the West, there's this real disconnect and isolation, not really a cultural understanding of some of the science, even of reciprocal engagement and attunement, and how important that is for developing children's brains and all of that. So, we see with psychedelic experiences, people can really go into what I call implicit imprints. So implicit memory being like a body-based memory. So we have our explicit memory, which is the way we usually think of memory, just we recall events in a timeline and what happened, versus implicit is how our body is holding things. It's also called procedural memory. So it's how you remember how to drive your car or ride your bike, because you rehearse that in this embodied way and it's just held in the body. So same way, implicit memories from events in our lives, be them positive or negative, are kind of stored, and then they can surface in the present moment. So imagine somebody's in an ayahuasca ceremony, and the experience opens up an implicit imprint of when they were an infant crying and left alone, which infants don't have a sense of time. Infants are completely dependent on their caregivers for their survival. So if a caregiver doesn't come, essentially they're going to die. So it's it can essentially be this experience of existential anguish of being crying and being left alone, which we know has been sort of like a sleeping technique that's been taught in, westernized societies, crying it out. So imagine a person in ayahuasca, that imprint opens and nobody comes again. And that level of existential anguish and pain is just there, and it's terrifying, and classical psychedelics have the potential of opening us up to quite terrifying or disorienting or confusing experiences, which again, to speak to the gentleness of MDMA, I agree with you 100%, Will, on that rational reason to work with MDMA with PTSD and people with pain. So I do absolutely share that concern around the pace of things and really getting enough therapists engaged in this work that have this level of kind of understanding that we're talking about.
So important. And, I just wonder, it's going to take a lot of education, and I think redefining psychology and psychiatry and just kind of like shifting the paradigm, because as you mentioned, I mean, my master's was in counseling. We had a somatic emphasis. So I think I only had 3 classes in somatics, but within that K-CREPT program, I don't think we had a program even really on trauma. It was in that mostly in the somatic emphasis. And I'm just thinking, wow, like, the counselors that went through my program aren't really getting a lot of this. Kind of blew my mind that it's not up to speed. So yeah, just thinking about kind of also this radical shift. And something you brought up just about like maybe retraumatizing with some of these experiences. I think this is interesting with some of the somatic work. And my thesis was really kind of taking parts of holotropic breath work and seeing how we could really incorporate it into, a counseling procedure. And something that came out of the somatic, I forget what book it was, but somebody was suggesting that a lot of the quote unquote primal techniques that came out of Esalen, holotropic breath work, Gestalt therapy, actually could re-trigger people because the intense catharsis and really dysregulating the nervous system. And so it's been really interesting to see, that big explosion really focus on catharsis. And I think about my own experiences when I was really exploring psychedelics in my early 20s. I was always, go big, go home, have the deep catharsis. If I'm not having ego death, I'm not doing it right. And actually how much trauma that has caused me over the years. And even like little bouts of HPPD and, just how it really stuck inside my body. And it's taken me to go back and learn about more somatic approaches and titrate the experience, develop a relationship with it, and actually start going deeper with that titrated approach. And it's so different than I think how most of us like either, think about this type of work.
I think, I don't know, that resonates a lot for me. I don't know. If I think back of like to all of my psychedelic experiences, I honestly, it's not even close right now. I feel like they have been net painful in the end. And it's not, I don't regret that per se, because I think for me, it's like, I don't know, when I started getting into this back in 2012, 2013, like I didn't know many people in the field. I didn't have many mentors. And so a lot of my experiences were by myself, or I didn't know how to really seek out the right experiences. And again, for me, I think it's because I've ended up, and we all have ended up as people who are facilitating healing. I mean, I think they've also been some of the best lessons for me, but I also don't wish sort of my experiences upon everyone necessarily, because it's
totally.
There's just this like, lag in learning. It's just going to take time, I think to have people, and I hope that it all moves in that direction, meaning that, but, another worrying thing for me, I was thinking about yesterday, is that, in the academic circles, like all these now universities have started these large psychedelic research organizations, and there's almost like a race within academia. And I don't know, I'm a bit worried about that, just because I've been connected to academia and academic psychiatry in particular, even up until recently. And so, if you start, we're starting to just let people who are classically trained in psychiatry, who we psychiatrists as a whole rarely interact with therapists, which I think are more on the end of being able to hold the emotions or the different experiences that come up in the room with a patient. But I think even psychologists, especially if they're focused trained on Freud, like Freudian methods, which is the majority of psychologists in the Western world, even then there's a big limitation on, what I would say is the ability to bear the pain that comes up. It's like, can we allow and facilitate people to really scream or to cry And I think that's where the therapist comes in, because I think if that feels like too much for the therapist, if they think that that's unbearable, that's when I think there's an impetus to try to put the lid on the experience. And I think that's where, at best, I mean, I hope it's like, okay, we're going to take our time. There's going to be more input from the somatic world. But a part of me also wonders that, as more research studies get done, if we have practitioners that don't know how to do this work, I mean, I think almost at best, it looks like the studies don't work, right? If you have, something that, I don't know, someone else doing psilocybin for fibromyalgia and they don't know how to hold the space, right? Again, almost at best, it's like, oh, it didn't really work. We didn't see a difference between the placebo and the psilocybin. But if at worst, we actually see the stuff come up, the therapist can't hold it or help bear it. And then you can get, oh my gosh, look, the treatment arm actually did worse than the placebo arm. I think there's possibility for that. And so I think that I really hope for pace and people really, working at the level that they feel comfortable with and not trying to rush into it just to publish more data.
Totally. It's like it speaks to the therapist's capacity for embodiment, because the more embodied we are as therapists, the more self-aware we are, the more attuned we are to the state of our nervous system, the more we actually know how to, in the present moment, harness techniques that are going to help bring ourselves into regulation. And to actually acknowledge that the state of my nervous system as a therapist is a therapeutic tool in the room, an unspoken one. And, to come back to what you were saying about just cathartic experiences and those sort of in the holotropic field and Gestalt world of like, the baseball bat and, just really one of the principles of somatic approaches and trauma-informed approaches is that we have an optimal arousal zone that when we're within it, we have fluctuations in our sympathetic and parasympathetic nervous system that are just normal everyday fluctuations. We get excited about something or we go for a run, there's increased sympathetic tone, we eat a meal or we're like cuddling with a friend or our pet, more parasympathetic tone, and we go in between. And in that zone of optimal arousal, or the window of tolerance, as Peter Levine labels it, that's where we can take in new information, because the parts of our brain that can integrate new information and learn are online. It's when we go outside of that window, either out the top into hyper arousal, fight or flight, or out the bottom, which is even less well understood, into a deep collapse of like a play dead, very deep, called in Stephen Porges' language, dorsal vagal shutdown. When we're on either sides of the spectrum there, we can't take in new information. So in many senses, these big catharses are actually popping out of our optimal arousal zone. So that's exactly, how we understand it in somatics, is like you could just be recycling these patterns. Whereas a more skillful approach is to actually, when those impulses are coming up, like a fight or flight response is coming up for completion, you might notice a client's hands are clenching or some changes in their body. And rather than expressing it through like flying into a rage and pounding a pillow, it's like, how does it feel if you just kind of squeeze your fist and then relax, and then squeeze your fist and then relax, and like get those muscles moving, but in a smaller way. And then what that can hold space for is reorganization. So you're actually doing a completion of a survival impulse in an organized way, which is how it integrates, right? Like to actually resolve and for the nervous system to take it in that actually this is over. We need to support organized completions of survival impulses, not kind of like disorganized, kind of looping in dysregulated states.
I love it. And I guess to bring this conversation a little bit back to pain, I wonder, like, how you guys were traditionally taught about pain in medicine, and like how they view fibromyalgia, and then bringing in, what you know about psychedelic experiences, somatics, and how that might be shifting maybe how we approach pain or view some of these chronic pain issues.
Yeah. I mean, I remember for me, one of the connecting the dots in terms of, it's interesting because, I had mentioned I had gotten a PhD. I was a very much like evidence-based person, and that science has to precede anything that I'm going to do. And I think as I mentioned, like I had all these experiences myself and observing other people at psychedelics over that time, where I was like more open to these other things, these physical changes happening, and that that I didn't understand, that I was never taught about. And holotropic breathwork really being the big entry into that. Actually, I remember that because I remember like going to, we know the same mentors, Lenny and Elizabeth Gibson in Vermont. I remember thinking that day going in there and like seeing my first session, I'm like, this is either like a legit cult, and I'm like, what are these people doing? Or I'm like, there's really something here. And like, so obviously I landed on there's really something there. But it was shortly after that, as I kept getting introduced to different people in the bodywork realm, where fascia came to mind. I remember learning about fascia in like my early medical school, and we're talking now like probably early 2000s, where fascia, I remember literally it was taught to be sort of like dead, not dead physically dead, but it's just like non-engaging connective tissue. It was just like this stuff that was there that like, basically surrounded all of our organs and different systems, and it just kept stuff together. And sometimes surgeons will cut it, and depending if there's like sort of a muscle trauma, but it was never thought of or as honored as being anything functionally significant. But once I started digging more into the bodywork realm and Rolfing and other stuff, people kept talking about fascia, and I basically connected all these stories about fascia with what I was seeing functionally with holotropic breathwork after I started assisting the Gibsons with some of their sessions, and being like, wait, these things that like we're talking about, and energy movements and pressures and releases, they all seem to be following these like fascial lines and fascial planes. And I'm like, and then I just started thinking to myself, yeah, how are these things connected? And it felt almost like, oh my God, like again, this thing that Western medicine had taught me like really wasn't doing anything. I'm like, maybe this is like a massive panacea into physical wellness and illness, and then yeah, and it was interesting because the more I talked to non-medical professionals in the wellness world, people were like, duh, of course it's the fascia. So it's I don't know, it's been this like going back and forth between things that I thought were true and things that I had held on to for a long time, and being more open to just like the other things that are. And so yeah, luckily now there is much more talk around fascia, but yeah, that was sort of my intro into my journey of transition.
Thank you.
Yeah, a similar experience. Well, in anatomy, really just like cadavers, in Western medicine, we're studying essentially a corpse,
Yes.
that's not alive. And in a way that, like you say, you cut through the layers to get to the organs, like the things that we're studying that are functional, and this sort of not really much attention given to this complex connective tissue that I'm also fascinated in. And whereas in other systems of healing, whether that be traditional Chinese medicine or Ayurvedic medicine, the study has been primarily of alive beings, and careful observation. And so that's one really interesting distinction in sort of where we go with our lens of biomedicine and sort of reductionism, and breaking things down to their constituent parts and getting more and more granular, which gives us really important information, not to denigrate at all what's come through reductionism and biomedical science and understanding a lot about function. But I think it's what's missing is that connection, as you say, the connectivity between like different functioning systems in the body. And that's where, I didn't mention in my intro, but I studied functional medicine through the Institute for Functional Medicine in the States. That's just this more systems biology approach that is like looking at all the interacting systems in the body and looking at the human organism as like an open ecosystem. And it's like, if illness is the emergent property, then what's in the way of the natural impulse of healing? What are the missing inputs? And sort of understanding, the role of the gut and the immune system and how that translates to skin and inflammation and other things. So again, it's kind of like when you bring pain into the equation, I think my training has largely focused on what analgesic agents and what are their mechanisms and what's first line, second line, third line, fourth line, in terms of like a pharmaceutical approach to managing pain, which we know, gives maybe at best 30% reduction in symptoms, which is at best about as good as a good placebo response. So not the end game in treating pain clearly. And also, I think, at McMaster in my training, I was there in 2004 onward, and there certainly was the biopsychosocial model was mentioned, not specifically in relationship to pain, but at least in relationship to how we understand people. But then once you get into practicing medicine in the system, our system, at least here in Canada, just doesn't really have a lot of room or funding for interventions that are actually going to be really effective in a biopsychosocial understanding. I mean, case in point is just the total emphasis on physical illness and physical, procedures, whether they be pharmaceutical or surgical, whatever, to address health. And this lack of attention and funding to mental health, to psychotherapy. In Canada, we have universal healthcare, but we don't have universal access to psychotherapy. And really just this bridging of this, of the mind body, this false disconnect of mind and body that modern Western medicine is sort of has come out of, industrialization and 400 years ago, Rene Descartes and the Cartesian sort of mind-body dualism, where mind is prioritized, or even mind and soul, but the body is like this corpus, this sort of low thing that is just seen as to be, it'd be even in modern medicine, when people get sick, it's like this. You can almost see this philosophical orientation of this. The body is not to be trusted. I've been betrayed by my body. There's a lot of fear people have towards their bodies, which I think is perpetuated sort of in how Western medicine holds things in general, not necessarily intentionally, but just through sort of the legacy of time. Whereas, in my postgraduate sort of learnings and forays into somatics and trauma and functional medicine, it's actually the mind-body split is false. And every single moment, my felt experience is informing my cognitive processes and my thoughts, and vice versa, right? And so I think where this then brings us in terms of pain management is needing to really acknowledge this as true and start to, I think, really empower people back into trusting the wisdom of their bodies, which is what psychedelic assisted psychotherapy, I think, is really leading, with most research programs in terms of therapist training, emphasizing this trust in the implicit innate healing intelligence of the body, that we can trust that. And, to me, it's important when we bring an anti-oppression lens as well. Because of how we can kind of explore how this sort of casting away of the body and has also played a role in or understanding of oppression, and how oppressive forces can actually change our relationship to our bodies. And in ways that are really meaningful in terms of how people are holding themselves, how people experience themselves. And I think this shift towards trusting our bodies and the wisdom inside is where I think we're going to see things go, where I hope things will go in terms of sort of how we hold things. That's very different from what the culture of what I was exposed to in my Western training.
There's something you mentioned just about how we view the body, and maybe talk about the body in maybe negative ways, or people feel like their body has failed them. And I'm just going back to that session I had 2 weekends ago, or last weekend, and the narratives that maybe some of us have, especially around trauma. And so, yeah, I definitely suffer from chronic pain, huge scar on my abdomen, adhesions, scar tissues, pulling. And the one thing that came up was, what are you telling this part of your body? And I wonder with people with, certain chronic pain issues, what is the narrative around how their body is functioning, and how that continues to maybe perpetuate pain, is having this negative narrative, or my body has failed me. What is this thing? I hate my body.
And I think of just, judgment of I mean, I think it's multi-layered. I think it could be like cultural, oppression of the views of the body. It could be religious oppression of the views of the body. Like I was raised Jehovah's Witness, and so like I have a lot of like, waist belt down trauma from religion, and I think actually all a lot of Christian based religions are very much like the body is sinful, sex is sinful, pleasure is sinful, and so that's something I just happen to be like working on a lot myself right now. And it was interesting. I was working with a Rolfer. I'm getting some sessions by someone done in Rolfing, and she's had years of experience and seen just like hundreds, if not thousands, of different people. And it was something that was painful for her. She said something that I took as very painful a couple of weeks ago, where I was talking to her about, I was like, I don't feel my lower body, and because she was telling me to do different movements, and I'm like, I don't understand like what you're saying. And then she actually, I don't know, we were talking a bit about it afterwards, and she was like, Will, she's like, you have some of the lightest legs I've ever worked with. And so it was, in a way, it was just like, God, I'm like that. It was almost confirmation of this like, yeah, this challenge that I've had. But it's like, I almost think about like the fascia, as we're talking about connectivity between all these things, right? The mind, the body, etc. Like what bigger evidence for me of connectivity in the body than there is the fascia, right? There's nothing else that just follows all the lines of the body, all the different parts of the body than fascia, right? And so I don't know, I've started this like, thinking about like, is fascia, does it tense up? Does it undergo its own like contraction and trauma? And is that why she describes my legs as being so light? And is the tension around this trauma around the muscles or the joints, etc., something that chronically, again, causes physical pain, physical suffering? And something else I wanted to share that was an early indicator to me of fascia was ketamine, actually, and the incredibly open movement I think that I've experienced with ketamine. I've had nasal treatments, I've had IV treatments, IM treatments, and it's also known to be like this beautiful thing that people love to use for movement and dancing. And I started because in my first intramuscular ketamine experience, like I sat in my doctor's office and I was like doing all these different movements, which at the time I didn't know what they were, but they were different yoga poses, and yoga's nothing I've ever been into. But I was able to do like and flex and be just more supple in so many different ways during my ketamine session. And that made very little sense to me at the time, but I was like, wow, is there, and I don't know, I know we're going on a little bit of a tangent, but I've thought before, like, I wonder if ketamine, right, it's so physically dissociative and it's so unique compared to the other psychedelics. Is it almost like opening up and loosening the unconscious of the fascia itself, and is that why we're able to move and dance and flow from a physical nature, much more differently than with other psychedelics? And I don't know, just like some ideas are flowing right now. And then like Bexon, the company that I'm working with, which, the flagship product is really a subcutaneous version of ketamine that can be sort of administered mobily. And, over time, is we're targeting chronic pain, and I wonder if in some ways it might be, this is part of the mechanism of why it seems to work for chronic pain, because it's like this like subtle opening of fascia. So anyway, those are just some different ideas that came up.
Yeah, I mean, I've also experienced a similar thing, and I had experiences with both sublingual and intranasal ketamine as I was healing from post-traumatic stress disorder. And, as a somatic therapist, initially, I kind of had this bias against ketamine. I'd never tried it before. I just thought, well, it's a dissociative, like it takes you out of your embodied experience. How could that be therapeutically beneficial? But then to actually experience sort of what you're talking to is this kind of loosening enough that shifted my internal experience of my body so that I could experience I'm still in my body. I'm not fully, we're not using it at anesthetic doses where you're actually fully disembodied. It's just changing your orientation to your physical embodiment. And, Eckhart Tolle talks about the pain body. And to me, it's almost like this notion of a pain body and total pain encompassing both physical restriction and tension and also emotional heaviness and how we're holding that in our tissues, just kind of loosening enough to experience oneself differently. And I wonder how much that even plays into the antidepressant effects of ketamine, right? And to tie it back to MDMA too, also and other psychedelics enabling this like different, like a new experience of oneself in the felt sense temporarily under the effect of the medicine, and what kind of doors that can open for people. And, as you were mentioning with pain and people's relationship to pain, and like maybe having aversion to their bodies or feeling betrayed by their bodies, one of the things that we know in healing chronic pain is that we need to help people reconceptualize pain. And perhaps pain, instead of being this big, bad, awful thing that's happened that I have to live with, it's like, well, what if pain had a voice?
Yeah.
What would it be saying? What if our body mind is intelligent, then what is this manifestation of physical pain about? And to get curious about that, and to then be able to explore it, and with the help of psychedelics, and in this case MDMA, which enables increased self-compassion, just a more positive valence, like taking down the valence of negative biases, which we know people carry with chronic pain. To me, there's tremendous opportunity to really shift our internal relationship, not only in how we think about it, but truly in how we experience ourselves. And to me, it's like that experience, and then the emotional experience that comes with that is what is really going to anchor learning and really be a factor in enduring effects. When we really shift our attitude and we have a very powerful emotional experience in terms of maybe reconceptualizing who we think we are, our relationship to our pain, and that has like a very positive emotional valence, then there's this opportunity that's really going to stay with us. If a traumatic experience can have such a lasting impact on us, well, why not also an extremely positive experience, and one that's shared relationally, where we're witnessed and there's connection, and I think that's part of why we're seeing, with PTSD, such enduring effects at 12-month follow-up. Participants, in the phase 2 data, they actually got better at 12 months than they were even at the study termination. And what's behind that? I think there's a lot, but shifting attitudes, shifting behaviors. So yeah, it's really exciting. It's very paradigm shifting in how we think about healing.
Yeah, it makes me wonder, like, what would be an integrative approach for you with healing? And, as you were mentioning ketamine, Will, and just how, it's a dissociative, but also kind of getting in touch with the body. So before I had that bodywork session, I actually had a CAP session. And so it was really interesting to go through the psychotherapy aspect and work somatically with that, and then actually transition to do body work and get in the body that way right afterwards. And I found that actually the CAP session was kind of interesting. I was able to work like with the psychic material, but the body work session allowed me to go so much deeper into this stuff that I haven't been able to touch into in years. And again, I think it's with working with that fascia, working with those memories in the body, like learning how to like slowly release it, stick with the process. And it was really fascinating. And I was like, oh, wow, I would love for this to be an integrative model. Probably pretty pricey, but I think there could be some benefit there. So yeah, just thinking about like an integrative model for pain. Any thoughts?
Yeah.
Maybe we'll wrap up. I know we're at an hour.
Yeah, no, I like that you mentioned this piece about the CAP session or ketamine session, just because people don't know what CAP means before your bodywork session. Because actually, the Rolfer I work with, she has had experience working with ketamine. She herself has worked with a couple of people who had prescriptions from their physicians, and so we're like exploring that. But over the last 2 years, especially, I've actually heard through a grapevine of a lot of actually non-physician, non-psychologists using ketamine as adjuncts to their work, including, as I mentioned, Rolfing, including acupuncture, including many different sort of what we think of as non-traditional medical approaches. So I think that there's people out there already doing it, and so I think integrating that would be really nice. And potentially it doesn't have to be more expensive. Like I wonder, Kyle, like if because body workers just they're if they continue to do the work that they do, but you add a prescription of intranasal ketamine or something, I wonder if it may not have to be such an expensive model.
Well, it was like right after, so it was on the tail end. Like I finished my CAP session, and then I just had the massage scheduled right afterwards.
So
Yeah, touch can be so integrating and so grounding. And, with folks with especially fibromyalgia and central sensitivity, touch can be really challenging because of the increased sensitivity. What feels like a light touch to you or I feels like painful when there's central sensitization. So sometimes, massage therapy, if recommended, ends up kind of like backfiring or really not being something that's helpful, even though when we look at the role of touch developmentally and how important it is to like building that brain architecture and to self-regulation and feeling connected, and the lack of it and what that does, that speaks to the importance of touch therapeutically, and whether maybe it's not so far as like massage or rolfing, but, in the psychedelic assisted psychotherapy models, there is a role for touch. I mean, it's one of the things I taught about at CIIS recently in my module is like, how do we approach touch? Most therapists are not trained in touch and maybe feel like a little concerned about using touch. But you see, when you watch Michael and Annie Mithofer in their, MDMA sessions with their participants and the videos, like I saw in my training, where the role of touch really is important. And to talk about, like where touch was absent developmentally to someone, and now it's being brought in as a corrective experience, it can be so powerful. Or even just the act of, I reached out for support so many times as a child and I was never met. So I became just like, that avoidant personality, or just became like, okay, I'm not, it's so existentially painful to reach out for support and not be met. But then, in a psychedelic session with therapists you trust, reaching and being met, like really actually physically, even if it's just holding a hand, the power of that. So I think and this is why I feel the somatic lens really speaks so skillfully to, even if we're not putting person on the table and doing body work, we're using invitational language that invites exploration of felt experience. There's conscious and ethical and consensual use of supportive touch. And I think that that's a bridge into potentially for pain patients, if they have a positive experience of non-threatening touch, maybe in an MDMA session, that might actually bridge into being able to tolerate deeper forms of body work and really grow in one's learning and capacity in receiving touch. So, yeah.
Yeah, I think in the breathwork world, we talk about that as like errors of omission, errors of commission, and that hand holding is it's a form of body work and is really it helps to resolve a lot of that stuff if you didn't have it at some point in your life. So. Awesome. Well, we're over an hour. I feel like we could still go on and on about somatics and just everything. This seemed to just fly by. So I want to thank you both for your time. Devon, anything that you want to close with? And maybe any links that you want to share, any events, or just, pitch yourself.
Sure. Yeah. So in terms of, getting in touch with me, my website is drdevonchristie.com. I'm also on Instagram and Facebook, Dr. Devon Alexander Christie. And then with Numinous, I mentioned the clinical trial that we're doing. So for any Canadian listeners that are interested in applying to be participants in our PTSD study, or as well, we're also doing a psilocybin-assisted therapy for substance use disorder, also a compassionate access open label trial. You can go to numinous.com and sign up for our newsletter, follow us on Twitter, on Facebook or Instagram, and we will be announcing how potential participants can apply. We haven't gone into enrollment and screening yet, but in the next month or two, we will be announcing the portals. And for the MDMA study, it's going to be a MAPS hosted website where people can submit their applications. And also just to stay up to speed on everything that Numinous is doing, our model is very much founded in the things we're talking about today, trauma-informed care, mindfulness and embodiment-oriented approaches, cultural sensitivity and humility, and really relationship-centered care, creating community, connection, recognizing, especially right now as we're seeing with COVID-19, the impact of isolation on mental health and mental illness. So I'm really excited about what we're doing. So if people want to follow us at Numinous, I'm happy to see people there too.
Awesome. Wonderful. And Will?
You could just enter my name on Instagram or, just my website, willsiumd.com.
Awesome. Yep. Well, thanks again. Really appreciated it. And we'll catch everybody on the next episode of Psychedelics Today. Take care, everybody.
Thanks. That was so fun. Thank you.